see is that once obesity is considered a disease, it has to be treated as well. But the question here is that why is it so common? Why is it becoming a big issue nowadays? Basically, it's primarily a lifestyle, and that's the single biggest factor as to why you're seeing obesity increasing day by day. If you look at the estimates from the Western world, it's pegged at something like 40 to 50% of their population are struggling with obesity, and I think the Indian data is not very different either. At least if you look at the urban landscape, the metropolitan cities, the data is not too different. So I think primarily the root cause is the caloric excess that we actually consume, and the caloric expenditure is actually not in keeping with that caloric excess. And I think that's the single biggest deciding point.
Thank you, Doctor. I mean, yeah, that's a true fact. How the caloric value is mattering us, and the main question that we actually have here is that how do you determine that if I am particularly eligible for this surgery or not, and what is a key factor that each of the the people should be considering for this eligibility?
See, I think before we get into any semantics or terminologies, one thing is for sure: when one views himself, or when his or her peers look at them, it's right there that somebody is really, really, out of shape, and we call it obesity. Initially, it's a perception, but if you were to go by numbers to quantify it, we have something called the body mass index, which is weight in kilos divided by height in meter square. And once you plug in these numbers, the formula will give you what's called a body mass index. And based on the body mass index, we actually grade the obesity as overweight, grade 1, grade 2, grade 3 obesity. And then depending on the body mass index, we actually go about treatment, deciding on the treatment options. But I think more than that, we are also looking at the constitutional makeup. It's not only the body mass index that we actually go by. I mean, it's not like a cardinal thing as such, because a lot of people who have very low body mass indexes, but they have a large pot belly, and that may be very specific to one population. Because if you look at the Asian population, we are known to have pot bellies. In these situations, we don't completely go by the body mass index alone. We also look at the overall perception. I mean, is the tummy really, really big? And if it's looking very unsightly, and if it looks like it's going to create problems, then that's right there. We actually, irrespective of the body mass index, but by and large, the body mass index will give us a good cue, give us a good grounding as to how to proceed with these people.
My next question is to our next presenter over here, Dr. Vivek. I was asking a general thing about this, the whole surgery aspect, due to your vast experience, you could share this also. How has science helped us in order, I mean, the technology helped us from the previous experience towards now, and what are the latest things that ensures that this whole procedure is really risk-free?
Previously, there was maybe from 50 years back, there was no other option for the obese patients. It was only diet, exercise, and some drugs. Then people started doing some surgeries on for other purposes, whereby they found that some rerouting of intestines and some manipulation of stomach and intestines resulted in weight loss, which was not expected. So then they started thinking, researchers started working on it, and that found that there were some group of procedures which can result in weight loss, and they started improving it. But still, the results were not that good at the initial stages, especially because the surgeries was done in an open way. You have to open up the abdomen, and it resulted in considerable amount of morbidity. Then to take a long time to heal because a thick abdomen takes a long time to heal from a lot big incisions. Then with the real revolution, the change came after the advent of laparoscopy. And suddenly the scenario changed. Then patients who underwent laparoscopic procedures, they started recovering fast. They were post-op time to return to work was shorter, and they were overall the patient comfort was suddenly improved, and also the procedures also started evolving. So nowadays, after, we have a good number of procedures which offer a good weight loss without uh, producing any significant morbidity or mortality. So overall, there's a trend towards minimally invasive procedures with uh, significant weight loss, but a reduction in the morbidity and mortality. Also, the anesthetic aspects and other cardiology workup and all those has resulted in good giving us a good pre-op assessment. So which patient will benefit from which procedure, and so that overall the trend has been that the procedure becomes safer and safer to the extent that it is almost comparable to the similar procedures like lap hernia or lap cholecystectomy, like that. So nowadays we can confidently offer these procedures to even high risk patients who have cardiac problems or other problems with obesity.
Dr. Tom, as we were discussing, I mean, we have seen another question that was coming up, will we gain weight after the surgery? That was a common thing that's been asked over here. So, I mean, the value is good, and after the surgery is performed, does the weight gain, or should we practice some health? We should consider doing some exercise follow up or something. Can you just be elaborate on that part?
There are two aspects to that question, really. I would answer it in two ways. One is that there is a weight loss which happens passively, which is merely by virtue of having done the surgery only and with absolutely no effort from the patient, they lose, um, the said weight, which is close to like 35 to 40 kilos on an average, is what we've been seeing. But you can hope, bigger or people with larger BMIs can lose much more. That's a different question altogether. But generally, as a ballpark figure, it will be close to between 35 to 40 kilograms. And this will happen passively without much effort from the patient. But at the same time, it doesn't mean that the patient can just lie back on his or her back and do nothing about it. That's something that we will never encourage, because it's definitely important to as a civic sense would require anybody to have daily exercise, some form of exercise or the other, and I think that applies to these people as well. And then also for keeping themselves toned up, keeping their muscles, the overall muscular function and the overall vitality. It's important for these people to exercise, no doubt about it. But it's not that we would prescribe additional exercise to these people, or they should be looked at any differently. But generally, what we see in these people who have undergone bariatric surgery is that it's like they it's like a newfound life to them. Means they lap up this new feeling of they feel much lighter, they feel much more effective, they are more effective in their jobs, and they feel like exercising more and more, because every day when they look into the mirror, they look better and better. And their waistline also will talk to them, meaning that they keep having to shift to clothes which are much smaller, and that happens like on a weekly interval itself. So they need to go out shopping often, and they feel that the moment they see their waistline drop, it's a very encouraging feeling. So then automatically they they find a spring in their life, and which motivates them to exercise. I have people who walk like 10 kilometers a day. I mean, we didn't ask them to, but they want to do it on their record because they want to lose more and more weight, and that's a good thing. That's a very positive thing. So like I said, two things. One is there is a passive weight loss, so even if they didn't do anything, they'll still that 35 to 40 kilos is a ready reckoner. It's going to happen even otherwise. But you throw in that exercise, you will expedite the weight loss. Your weight loss will be a little bit better, and also you get that spring in your let's say step, because you feel more energetic. You have that zeal. You'll glow altogether because it's good for your skin. It's good for overall vitality. So that's that's with regards to bariatric surgery, post bariatric surgery, and the need to exercise.
Thank you, sir. Dear attendees, I would like to remind you that we have a question and answer part at the end of the session, and possibly we have time now. Let's just go to the slideshow where we are actually presenting the whole aspects of the discussion today that we have. So let's begin. Okay, I'll just ask, this slideshow will be presented by our two doctors in conjunction. The first part will be dealt by Dr. Tom, who will be explaining the main things, and the surgery area will be dealt with Dr. Vivek. So I'll just pass over to doctors.
Let me first introduce myself. I'm Dr. Tom Babu. I'm the consultant endocrinologist and bariatric physician here at Silverline Hospital. And I'll be talking to you about the medical aspects of obesity, and also, set the stage for, who are these people who would actually require bariatric surgery, in my view. So, it was only recently, that is around 2007, we actually came up with a definition for obesity. And this is because it is only, very recently, around that time, we actually recognized obesity as a disease, because before that it was only in the realm of like a cosmetic problem and not anything else. But it was in 2007 we realized that obesity is actually the common soil for a lot of lifestyle disorders like diabetes, hypertension, dyslipidemia, obstructive sleep apnea, and so on and so forth. I mean, I just named a few, but there can be a whole list of conditions associated with obesity. So the definition is quite simple. It says that it is a condition where there is excess accumulation of body fat. Now that's simple. That's very obvious to us. But what we don't realize is that this excess in body fat can affect these people in an economic manner, in a mental manner, and it affects their physical health too. So it has a sting at its tail. That is something that one must understand. Next slide. So as I alluded to a little while before, we have to actually quantify obesity, because only then we can actually put a number on it and then decide how to treat it. So this is done very elegantly by using what's called a body mass index calculator. And the BMI is nothing but you actually plug in the weight in kilograms divided by the height in meter square, and then you come up with a number. And if your body mass is less than 25, then that's okay. But if you're an Asian, actually that number is a little bit, the cutoff is a little more stringent. So if you're about 23, you need to start worrying, because between 23 and let's say 30, you are in that overweight category. But if you're over 30, then you have what's called grade 1 obesity. And if you have a body mass index of over 35, then you're in bigger trouble because you have grade 2 obesity. And if you have a body mass index of over 40, then we call it morbid obesity or extreme obesity. Now, why we call it that is because people with morbid obesity are sitting ducks for a host of issues like diabetes, hypertension, coronary artery disease, osteoarthritis, etc. So this is why we've categorized obesity in this manner. Next slide. So basically, if you look at obesity is, it's quite simple. I mean, if you want to conceptually look at it, because obesity happens because of one of these two variables. One is that there can be either a caloric excess, that is, you're taking more food than required, right? And from the food comes calories. That's why I said there is an increased caloric intake, or there is a caloric excess, or you can be expending less, or your caloric output, or the way you're burning these calories can be deficient. It may not be in keeping with the caloric intake. So two reasons. One is either you taken more food than that is required, or you burn less than that is required. So if either one of these variables are deranged, or if you have a problem with one of these variables, then you land up as obesity. Obesity can be the net result of this derangement. Next slide. So basically, if you look at how human beings are made, we are made to maintain a tight energy homeostasis. When I say tight energy homeostasis, it means that when you're hungry, you're supposed to eat, and when you're not hungry, you don't eat. So that's how this energy homeostasis is maintained. So earlier, if you look at how we've evolved, how human beings have evolved, when we were hunter gatherers, means, just go back, when you throw back to, let's say, 1 or 2 centuries before, what was happening is that we were either growing food for consumption, or we had to hunt for food. Either two of these things were happening, and all these involved a lot of physical activity, and also you did this only when you are hungry, and you didn't eat when you're not hungry, because one, the environment or the circumstances did not allow that, and two, the body was tuned to such a way that only if you're hungry, you actually go out, you either grow and eat, or you hunt and eat. But so basically, we are made to maintain such a tight homeostasis. But what's happening is, next slide. What's happening is that what you're seeing in front of us, or what we're dealing with every day, is that we have access to very rich food, very easy food, and it's all around. You don't see poverty anymore. Um, Around you, you're increasingly seeing plenty. So, which means that automatically the environment is obesogenic, means that the environment by default is it is right now, it is in such a way that it will make you put on weight, unless otherwise you fight it. That automatically what you see around is obesogenic. So that's what we actually deal with today. And as you can see in the slide before you, you can see how we've evolved from hunter-gatherers, where people were really lean and mean, to now, people with pot bellies, and people who are like really, really, fat all over. And obviously that will trigger off a whole lot of issues. Next slide. Next slide. So basically, what drives all this is man's hedonistic tendencies. Hedonistic means man's pleasure-seeking kind of behavior. So that is a primal instinct where man always will seek pleasure. And one of the ways in which man gets pleasure is by eating. So when you carbohydrate, uh, tendency is keep, to keep gorging food time you actually have a chance to. And what's making the matter worse is you have food all around you, and most of these foods are energy dense, and one has no idea as to what you're actually slurping in, and so the net result is obesity. Now, the common myth is that obesity means a hormonal issue. Yes, of course, 5% of people who are obese may have a hormonal problem or a hormonal imbalance, but 95% are what's called constitutionally obese, means that because of genetic kind of a predisposition, means there's somebody in the family who is obese, or they may have been obese right from childhood. They start off as a childhood. Start off as childhood obesity, and then move on to becoming obese adults. But that's like 95%. In rare cases, like somebody with Cushing syndrome, where you have like a glucocorticoid excess, or people who are undergoing treatment for diabetes, a lot of drugs can cause weight gain, and a few rare hormonal issues can present as obesity. But like I said, that is a minority. Only a small percentage can actually manifest that way. And the common myth is thyroid problems, namely hypothyroidism, can manifest as obesity. But that is really a myth, because of hypothyroidism, maximum somebody can gain weight is roughly 3 to 5% of their body weight. So, for example, take like a 90 kilo man or a 100 kilo man, or a woman for that matter. The maximum, because of hypothyroidism, that they can gain is like 3 to 4 kilos, which to my mind is not should not be noticeable, because if somebody has noticed a weight gain, then there is a very remote chance that it is because of hypothyroidism alone, and there is more of a likelihood that it is because of constitutional. Next slide. So if you look at the implications of obesity, it can affect almost every organ in your body, but mainly what we are concerned about is that it puts somebody at risk for coronary artery disease, diabetes, hypertension, dyslipidemia. It can produce severe pancreatitis. It can predispose to certain forms of cancers. In women, it can be in form of breast cancer. You can have liver cancer. You can have cancers are seen more in obese people. These people are more prone to varicose veins, and you can have ulcers as a result of these varicose veins. It can be sometimes very painful as well. Joint problems, osteoarthritis, which requires eventually a good percentage of these people will require knee replacements, hip replacements, and it can affect their mobility, which can worsen the obesity. You can have gallstones as an issue. In infertility, because of polycystic ovaries, can be a big problem. We have a lot of these bariatric surgery as a cure for polycystic ovaries or infertility, and these women can conceive just like that after the surgery. These people are prone to what's called fatty liver. The fatty liver can progress to cirrhosis liver, and they can some of them can have obstructive sleep apnea, which which is manifested as snoring at night, and then they feel groggy in the morning. With weight loss or with bariatric surgery, obstructive sleep apnea can be reversed completely. Next slide, please. So the treatment options are based on the body mass index. So in lower forms of obesity, or lesser forms of obesity, we go with what's called lifestyle modification. But as the obesity becomes more and more severe, we resort to what's called pharmacotherapy, or we treat it with drugs, and ultimately we actually opt for a surgery in severely obese people. Next slide. We start off with what's called lifestyle modification. So in lifestyle modification, what we encourage these people is to exercise more, to avoid, obesogenic environment, which is caloric excess. So we treat them how to modulate their energy intake. We treat them smart ways to eat and to choose food groups which help in weight loss, etc. We also ask them to set realistic targets when they exercise, and then proceed with that realistic target, because if they set unrealistic targets, it doesn't work out, and then they give up very easily. So we teach them to actually perceive these things in a more practical manner, and then embark on it, so that their targets are achievable. And once these targets are achieved, then we move on to another target, like that. And this way is quite effective. A lot of people can lose a lot of weight and can maintain that weight loss also in this manner. But often it's very unrewarding, because they can't keep up these sort of the resolve for long, and they quickly go back to earlier what they were earlier, and they gain weight. So that's why cognitive behavioral therapy or lifestyle modification by itself does not work. Next slide. Um, then in terms of the when you have grade 1 or grade 2 obesity, we resort to what's called pharmacotherapy or drugs. These drugs mainly, one, they act in any one of these three ways. One is that they increase the fullness, means they make the patient feels full suddenly. Or second mechanism of action is that it increases the thermogenesis, means the rate at which the body burns the calories is expedited. Or three, it can decrease the absorption of the fat from the gut. Means it interferes with the absorption. So mainly it's lipase inhibitor, which prevents the absorption of fat. Next slide. So the only drug which we use today, you can see three drugs in the slide, but orlistat is the only one we actually use today. And even so, orlistat is a lipase inhibitor. Now, what orlistat does is it inhibits the absorption of fat. But the truth is that orlistat is a weak anti-obesity agent. The maximum somebody can hope to lose is 3 to 4 kilos in a span of 12 months. And orlistat, the problem with orlistat is it can produce gaseous distension of the abdomen, so it can be a little bit inconvenient. So we use it as a bridge for somebody who's trying to lose weight before bariatric surgery, or somebody who's trying to conceive, or certain select situations like that. But otherwise, pharmacotherapy or these drugs as a whole are not that very effective. We find treating these people with these agents are underwarding, and it doesn't last for long. Now, the basic problem, next slide, why the pharmacotherapy is a failure is because they lose weight initially, but then the moment they come off the medication, they go back to the earlier weight. And the reason why this is happening is, I was telling you, we have a set, there's a set energy point, or there is a set point of an energy homeostasis. So our body maintains that very closely. It will not allow us to, so from a given body weight, because that is the energy set point that we are following, it will not allow us to lose, or it will not allow us to gain. So that is that set point. So by drugs or any one of the other ways, excepting surgery, moving that set point becomes very difficult. So we always go back to that set point. That's why these drugs don't act very effectively long term. So with this, I've come to the end of my discussion on the medical aspects of obesity.
Thank you, Dr. Tom. It was really elaborate methodologies, and all those things were very interesting. Now let's see how how the surgery options are available right now, and I welcome Dr. Vivek in explaining that. So,
Let me introduce myself. I am Dr. Vivekanand, bariatric and laparoscopic surgeon. So I will give a brief overview of the surgical aspects of management of obesity. So first of all, what are do we offer surgery to all obese patients? No. There are certain indications for surgery, and that is the most important thing is first we start with conservative measures like diet, exercise, and all. Once that fails, then we think of surgery in selected group of patients, that is the morbidly obese. So that for that we use the body mass index criteria. So body mass index above 40 in general, and in case of Asian population 37.5 is considered as a indication for bariatric surgery. And those with comorbidities, means those with diabetes, hypertension, cardiac illness, other diseases, the BMI is lower. So yeah, the cutoff point is lower because they have more likelihood of going into later on into problems. So that is 35 and 32.5 in Asian population. And the age group is 16 to 65 years. Below that we don't, or out of that range, we don't offer bariatric surgery. So as I previously mentioned, all procedures are done laparoscopically. That gives fantastic results. And we classify into two groups, surgical procedures, as restrictive and malabsorptive. What we mean is, by restrictive means we reduce the volume of the stomach. So it's the simplest thing we can think of. So the patient can person can take only a limited amount of food. So the energy intake automatically comes down. And the other thing is malabsorptive, means we whatever it takes is not absorbed properly, so that the excessive calorie and fat all are not absorbed by the body. So we commonly perform this restrictive procedure, and in this restrictive procedure, sleeve gastrectomy is the now becoming the gold standard procedure. And I will talk more about sleeve gastrectomy because that's the procedure that we mainly perform. So this is the commonest weight loss procedure, and it's increasing in popularity in all over the world. In India, it's more than 90% of bariatric procedures are done are sleeve gastrectomy. Here, what we do is the stomach volume is reduced by 75 to 80%. That is, the 3/4 of the stomach is removed, and only 1/4 of the stomach volume remains. And this gives fantastic results. And the biggest advantage is that there is no manipulation of intestines. It's the simplest procedure we can think of. And before like any other bariatric procedure, there is a detailed pre-operative workup to hormonal assessment, cardiac evaluation, respiratory assessment, all that anesthesia evaluation. All these are done. And once we decide for surgery, it's taken up for laparoscopically, done under general anesthesia. All laparoscopic procedures are done under general anesthesia. And the time is usually around 1 to 2 hours. And once the procedure is over, for 24 hours, we put the person on NPO, nilporal, and after that, liquid diet is started 24 hours after that. And the hospital stays around average 3 to 5 days. Usually, we discharge on 3rd or 4th day. And the regular diet starts 1 week after surgery, but in the reduced quantity. And person can normally go back to work in almost 1 week time. This is just a few slides. How is used to remove the greater part of the stomach. Only 1/4 is retained in the body. Next one. This is the finished procedure. But you can see there is a large portion of stomach is detached from the stomach. That is removed. So the remaining portion is almost 1/4, and that automatically reduces the amount of calorie intake that person takes. Why we prefer this procedure is because there are certain reasons. It gives excellent weight loss. On an average, it is around 35 to 40 kilos weight loss, but that can be increased with regular exercise. And this weight loss can be greater in person with higher BMI and by higher obesity. And also along with this, even this procedure is technically similar. It gives an excellent resolution of other diseases like diabetes. 80 to 90% you can say cure of diabetes, hypertension, or sleep apnea. All these comorbidities are resolved in a fantastic way. And these results are comparable with more complicated procedures like gastric bypass. So that's why one reason why we prefer sleeve gastrectomy, because this now is as good, almost as good as other more complicated gastric bypass, which have higher morbidity and it's a compared to lesser hospital stay. We can usually discharge the patients on 3rd or 4th post-op day. And it is suitable for all obese patients. Almost all patients can be taken up for this procedure, whereas the other procedures like gastric bypass and all, there are a lot of conditions where we cannot offer to the obese patients. And it's relatively safe. The complication rate you can see is less than 0.8%. That's comparable to the complication rate of a simple procedure like laparoscopic hernia repair or other procedures. Then technically similar. There is no manipulation of any other organs. Just the stomach volume is reduced. You don't have to deal with the intestines and other issues. And there are no problems with malabsorption and a condition called dumping syndrome, which can be very distressing. So these are avoided because we don't manipulate the intestines. And the weight loss, on an average, it is something like 1 kilogram per week. It keeps on losing weight for 3 to 4 months, and also beyond that, but at a slower rate. And there is no significant long-term side effects. That's the beauty of the surgery. Once a patient is through the procedure, they don't have to worry about other conditions like dumping syndrome or malabsorption. And no need for any lifelong medications. Only few multivitamin supplementation for initial 3 to 4 months. After that, they don't have to take any medications also. And hospital visits are very infrequent. Only annual visits are necessary after surgery. There's no need for any frequent visits, unlike in other countries like gastric banding, where you have to visit regularly. Here, only annual visits are necessary. And also, there's no need for any routinely. We don't have to deal with any other issues like excess skin being producing unsightly condition. But occasionally, some patients may need for excess, especially in the high BM body, high morbid obese patients. If there is any excess skin, that will have to be removed, but that can be done very easily. So that's called body contouring. After once the patient starts losing weight, some people, usually because of skin elasticity, that there is no such issues like excess skin. But especially in the high BMI, morbid obese patients or in elderly patients, there can be some amount of loose skin which can be later on removed. That's not at all an issue. And this is just a graph, two graphs showing the benefits of bariatric surgery. In the right side, you can see there is almost 30% reduction in death rate of the patients who have undergone surgery, because there are more comorbid conditions like diabetes, cardiac problems, all this get resolved. So the overall death rate is almost 30% less when compared to the normal people, people who had undergone surgery. Okay, next. Now I've been focusing on sleeve gastrectomy because that is the one we routinely perform, and that's the one gives one does fantastic results. But there are other options. Just for completion's sake, I am talking about another surgery which is also being done. It's called gastric bypass. This has one advantage you can think of, it that it gives slightly better weight loss, but the cost of having a higher complications like dumping syndrome, the nutritional deficiencies, and malabsorption, etc. So this and also this requires lifelong medication because of the malabsorption. The persons who undergo gastric bypass need to take multiple vitamin supplementation, calcium, and all minerals. They have to continue it lifelong, and then they have to have more frequent monitoring because they can develop nutritional deficiencies. So generally, our policy is we offer it as a second option. Once in very high BMI patients, in morbidly obese patients who undergo sleeve gastrectomy, if they find that they have to lose some more weight after a period of time, we can think of offering gastric bypass as a second option. Otherwise, routinely there is no need to put it as a first option. Thank you. I'm handing on.
Thank you, Doctor. Likewise, we were actually ending up this slideshow section, and we'd like to, these are the main, contact form in which you could give us a reply back. But before that, I would like to go for an, slight questionnaire again. The thing is, my question is to Dr. Tom. Like, if a person right now is actually having some sort of BMI, the way we have discussed before, BMI above 40 or then, right now, what is a step he should be doing? Like, if he contacts us, and how do you, from the first point, how do you treat him from the first, like the steps he had to go, and how do we reach here, and the quality that is given by Silverline, and how can you explain that, sir?
So, like I was saying, it largely depends on this individual's. First of all, I think it's his drive or it's his conviction to address his condition, and that is what we look for most, because often we have parents pushing somebody into something of this kind, um, trying to shoulder somebody into these things. So that is something that won't pan out. It won't work out for these individuals because it has to come from within. So we look at the importance they attach or the passion with which they come to us requesting help. And that's to me the single most important thing, because if that's not there, then I don't think we would waste time on these individuals. So we look at how badly they want this. So once we've ascertained that, and we have identified these people as good candidates, then obviously then we look at the history in detail in terms of what their body mass index is, as I was alluding to earlier, and then the comorbidities, like is there like a diabetes to go with, is there a hypertension, is there coronary artery disease, is there a whole lot of things that will be important considerations. But a few things. One is we need to rule out what is called type 1 diabetes, because then if it's type 1 diabetes, they will not the diabetes remission or resolution will not happen in these individuals, because sometimes in type 1 diabetes, these diabetics are generally lean, but there is no hard and fast rule, because nowadays you're seeing these type 1s masquerade with morbid forms of obesity. That there can be a case. So sometimes we, if we don't confirm that this is type 2 diabetes and not type 1, we'll be failing in the diabetes resolution front. So that is one situation. And then even while the procedure is being carried out, they can go in for a ketoacidosis, and a whole lot of problems can ensue. So we need to make sure what sort of diabetes these people have. Also rule out other rare forms of hormonal disturbances like Cushing's syndrome. That's something that we need to rule out. Also in women, rule out pregnancy. That's something that because often we can be misled, and a lot of women don't know that they're pregnant. So if we embark on a surgery of this kind, it can be catastrophic. So we need to do a urine pregnancy test, or confirm or rule out pregnancy in the ways that we do. And also what's also important is the cardiac aspect of it, because they are going through a surgery. It's done under general anesthesia, and the post-op recovery period is also going to be slightly stressful on the heart. So we need to ascertain that the cardiac part of it is okay. Majority of them actually have their cardiac status will be fine, unless otherwise some of them have congenital, means they're born with some sort of valvular defects and things like that. So in those situations, we need to be careful, but we have a good team here comprising of cardiologists. We have a team of physicians. We have the anesthesia team to back these people up. So generally, even if they did have some of these issues, we are still, confident in taking these people up. But in some situations, sometimes they just cannot go through it, and then we will then discourage them from getting such a procedure done. And also another procedure which is non-negotiable or mandatory is an endoscopy. Endoscopy is something that we need to do prior to this procedure. The reason being, we need to rule out anomalies in the stomach, like a polyp or like erosive gastritis. Because what happens is when the surgeon then dissects or cuts through, if they have like a polyp which we've not picked up prior to surgery, or if they have erosive gastritis, the suture, I mean the staple lines can bleed if we miss these situations. Yes, so that's why we need to rule these out, and that's why endoscopy becomes non-negotiable investigation as a run-up for bariatric surgery. Then also an ultrasound of the liver is, or ultrasound of the abdomen, sorry, is important to rule out liver disease, chronic liver disease, because we will discourage people with cirrhosis of liver to undergo such a procedure, because this procedure involves everting the liver to, or pushing the liver to, or retracting the liver to one side. So if they are cirrhotic, the liver can come into pieces, and it can be catastrophic. So we need to rule out cirrhosis. That's why ultrasound abdomen becomes very important. So these are some of the tests that we usually do prior to surgery.
Right, sir. That was good. I mean, okay. Now, in a straightforward way, if people were there to ask, like, what sort of diseases are being eliminated or cut down or reduced after the surgery, what would you answer in that? Like,
Let's start with diabetes. So what is seen is there's almost 80 to 90% resolution or of diabetes. We call it diabetes remission. I refuse to call it cure for diabetes, because this diabetes will probably in another 10 to 15 years come back in some form, but at least for 10 to 15 years we can put it to sleep, send it to remission. Hypertension, slowly we tend to see the need for medication come down, but with diabetes everything can be stopped. Just the minute after surgery, insulins can be stopped, the most of the medicines can be stopped, or all in some cases, or in majority of the cases. Some of them require basic, like metformin, or some basic medications, but otherwise in 80 to 90% there's complete remission. Then the obstructive sleep apnea, the snoring part, it is like 100% resolution. These people can have 100% cure of obstructive sleep apnea. In women with polycystic ovaries, they do very well because these women are infertile also. That's why they come to us. So they conceive just like that in some months after the surgery. Though we advise them not to conceive for a year, some of them conceive immediately after surgery. Fortunately, so far we've not had any problem, but we still advocate at least 1 year period, a wait-in period before which they should not conceive. So then people with joint problems, people with osteoarthritis, with bad knees, bad hips, a lot of them, the ones who've been prescribed surgery actually do well immediately after they lose like 30 to 40 or 50 kilos. Then they don't need those replacements which have been suggested, or at least they get time to think about it, because their knees feel much better, they feel much lighter, they're up and about. People with varicose vein ulcers, they heal when you lose this kind of weight. These ulcers heal spontaneously. So these are basically largely the benefits that come out of surgery.
Seeing the positive part, it's very happy to know that this sort of surgery, bariatric surgery, is so much more effective. So as we all know, we have come to a part where we have ended up the discussion part, and right now it's come to a good point that having the surgery with people who have BMI levels greater than or equal to 40. They're advised to join us. You could shoot us an email, you could contact us for a free consultation. Anything is available. Now, right now, let's move on to the Q&A session where you could either type in your questions coming up, and we are happily available to answer it right now. And or if it's feasible, you could set up your speaker, and you could just speak to us right now. Anything that's coming up, we are available right now. Yeah, and Doctor, there is a question over here. It's actually coming from one Mr. Arun. He's asking, are there any activities that we shouldn't do after the weight loss surgery? I mean, strictly we should not something like sort of that. Doctor, yeah, I think Dr. Vivek would be answering that.
Actually, other than the immediate post-op period, we restrict the activities and diet. After that, there is no such a specific restriction that we recommend. They can have a normal life, except that they have to take the diet as prescribed. So they can have a normal physical activity. They can go to a normal work. Only thing is, as I already mentioned, the females, they should avoid pregnancy for 1 year or so. Otherwise, for other persons, there is no such any restriction or major restrictions. Like
Can I add something, Vivek? Also, I think it may be a good idea that for a minimum 2 week period, we would recommend these people avoid lifting heavy weights, because some of our patients, I remember, there was this one patient who had small children at home. So then the question is, can we take them, can we lift them up and all that? So obviously these children were like 6 to 8 years old, so they're quite heavy. So such activities can be avoided, because the abdominal wall is still just kind of healing up and all that. Generally laparoscopic procedure, so it shouldn't be that much of a problem, but still it may be advisable to exercise a little bit of caution for lifting heavy weights for around a 2 to 3 week period. But otherwise, as Dr. Vivek said, 6 to 8 hours after surgery, we have our patients back on their feet, all the tubes out, and we encourage them to walk, because the more they ambulate, the less the post-operative pain. But there is a that post-operative pain is going to be there, a little bit of a pain no matter what we do. There will be a little bit of a discomfort. I wouldn't call it pain, but this discomfort is much better when they ambulate quickly, or when they are on their feet, when they're up and about. The pain is much better, or this discomfort is much better, and then this continues. Once the patient gets shifted to the room, also we encourage them to walk around, and then we send them with an advice to walk more and more as much as possible. So the only thing is to avoid lifting heavy weights for like a 2 week period. And also when we discharge them, we ask them not to drive for 1 or 2 days. That is, on day 3 we discharge. So for like maybe a period of a week, we can try and not drive, because when you drive, it can put pressure on the abdomen. So theoretically, we don't want that. So post-op, after discharge, maybe 2 to 3 days, stay off driving. But after a week, you're back to normal. We have get off back to maybe New Zealand, or Middle East, or maybe African countries. So many of them, because they're pressed for time, so they need to kind of shorten this whole process, which we've done for them. And generally, they are all okay, they're comfortable. So we can shrink that process also. But these are some of the precautions that one needs to exercise.
Thank you, doctor. That was really good. I hope it answered the question. Now we have another question coming up. What are the chances of any complications after the surgery? So, that's a most important question everybody needs to find out, So, I would like Dr. Vivek to answer.
Yeah, this is done as a laparoscopic procedure under general anesthesia. So, as I already shown, there's the complication rate are less than 1%. It's on an average. That is comparable to other routine procedures being done, like laparoscopic hernia and all. So it's fairly very low. But there can be complications. Some complications I will mention. One is some bleeding from the staple line. There can be some amount of leak from the staple line. There can be blood clots forming in the lower limb. We call it deep vein thrombosis. We take precautions. For example, to prevent bleeding, we put sutures, then put drain. To prevent this clot formation in the legs, deep vein thrombosis, we give heparins. So these are just to mention. We can say these are the complications, but we rarely see this. And complications are usually more likely in a high or more morbidly obese patients. But even then, we have done nearly almost 100 cases without any significant problem.
Can I add to that? Manav, I've been in touch with you and to meet you on. So Manav, I think from our experience, Dr. Vivek and I and the rest of our team, I think of over like in the last 1 year or 1.5, we've done, I think, over 100 plus cases. And what we've seen is that one is generally a very safe procedure, and as Dr. Vivek said, the complication rate is like on par or lesser than simple like hernial repairs or appendectomies. So that's these surgeries are all on that let's say complication rate, which is less than 1%. So the ones we've seen is that in one of our cases we had a wound site infection, because this guy was diabetic. The sugars were actually prior to when he came here, the gentleman lives in the Middle East, so sugars were not very well controlled. So that is one individual. We had a wound site. It's a very local thing, and in like a week or 10 days, the wound usually it doesn't even require antibiotics. We don't even prescribe post-op antibiotics, because it's a clean wound and it's done laparoscopically. So that is not required. But in this particular individual, he went back to the Middle East, and we continued oral antibiotics, and in less than 10 days, the wound healed up. So that is the only one situation where we've had a little bit of a complication, if I were to call it that. But otherwise, generally, these procedures are generally very safe.
Doctor, there is another question coming up. Are there any tests being done to check for any leaks before the discharge?
I'll first take that, then I'll pass the mic over to. They actually look for leaks, means they fill the abdomen up with saline and to look for leaks. That ensure there's not even like a 0.1% leak. And generally with the technology that we have, the ceiling is like 100%. There's no room for leaks that way. And then they pass gas also to see if there are leaks. So several rounds of reinforcement is done right there on the operating table, and only once all this is done, the surgeon closes up and comes out. I'll pass the mic. He can fill you on.
Yeah, the first step we do is during the procedure, immediately after completing the transection of the stomach, we inflate the stomach with gas and use the saline to see any air bubbles come. So it's almost 100% that we don't see any problem. But in case it is there is some doubt, we put a buttressing, we call it buttressing suture. We put a reinforcement on that suspected site. So we before the patient is taken to out of the theater, we make sure that there is no leak immediately. And after that, every day we assess the patient bubble sounds and the patient's vitals, the temperature, breathe, respiratory rate, pulse rate, etc. So if any doubt, if we have any suspicion, only then we go for any further test. There is we call leak test. We give radio opaque dye and take X-ray so that we can visualize if any leak is there. But these things are not routinely done. We don't need to do for all patients. It's only this is any suspicion we do. Otherwise, this intra-op checking is all that is needed.
Thank you, doctors. I hope that answered your questions, Mr. Manu. Now let's move to any other questions. Okay, yeah, we have another question coming up from, it's like they're asking that, is there any case of any zinc deficiency or something that after weight loss surgery?
Not really, Naveen. Basically, if you look at the deficiencies that we actually commonly see, one is of iron. These are basically because of malabsorption, and these are mostly seen in Roux-en-Y gastric bypass surgeries, which is essentially a malabsorptive procedure. But in a gastric sleeve, which is only a restrictive procedure, there's not much of malnourishment or malnutrition as such. So this is why even the vitamin supplements and the calcium supplements and the rest of it can be withdrawn after like a period of 3 to 4 months very safely, because there is no malabsorption as such. But in malabsorptive procedures like the Roux-en-Y gastric bypass surgery, in those procedures, yes, there can be nutritional deficiency, and this is why they need to take nutrition supplements lifelong, and zinc deficiency can be one such deficiency, not to mention the vitamin D deficiency, the iron deficiency, the B12 deficiency, and so forth. But this is why we are huge proponents of the sleeve resection, because more and more across the world we are discovering the benefits and the simplicity of gastric sleeve versus any other procedure. And that's why even though in the past you had like an ileal switch which came up but which then didn't get popularized, you had BPD, that is bilipancreatic diversion, which came up, which didn't take off. So like that, but more and more the world is moving towards a sleeve, and that's our current thinking today. And no, the zinc deficiency is not much of an issue with gastric sleeve, but I'm sure that is a consideration in a bypass surgery.
There are a few more questions coming up from Mr. Manav. He's actually asked what sort of assistance is being provided for outstation patients. And with that question, I think it'll be really good if you can explain the history of the patients that has come from and where they came from, how assistance have given. Right.
We have quite a lot of our patients coming from Australia, New Zealand, from the Middle East, from those countries like Bangkok, Thailand, Malaysia, Indonesia, and all that. So we have quite a few of our patients come from outstation. So what we usually do is we actually communicate very effectively with these patients, as a preoperative workup, get to understand what their conditions are, try and get hold of as many medical records as possible. So completely be ready for these people by the time they come. So have a plan charted out and send them an itinerary of how it would be, how this whole process is. So generally what we try and do is we educate them as much as possible through the web, and it's like, and wherever required, we do Skype meetings, or we meet them using other media. So whatever works for the patient really, and usually it is a team meeting. Dr. Vivek, myself, our nutritionist, physiotherapist, we are all there together, collectively working these patients up, interacting with these patients. And once they touch base, means once they shore up their travel plans, we pick them up from the airport. Once they reach here, we actually have a group meeting. The team members will meet the patient, will brief the patient as to what is expected, what realistically will happen, the time frame, and so forth. And then, of course, there is this surgery per se, then the post-operative period, and then it is time to pack up and go back home, and wherever possible we try and arrange like a sightseeing, shopping, and all that for them, because on the third day they're ready to walk around. They love to stretch their legs a bit, look around Kochi, and then yeah, they are we put them on the flight back, and then we correspond with them very closely, and we collaborate with the primary care physician there, who can monitor these things. But basically, with gastric sleeve, very little monitoring, because there is no nutritional deficiencies, there is no real problems that arise out of the surgery per se. So it's very easy following these patients up, and as Dr. Vivek put it, annually we do the let's say vitamin D assessment, calcium, phosphorus, B12, and so forth. And then if they are diabetics, we keep close watch on their blood sugars. We look at the medications required. So basically, these are all can be done passively. We don't have to do anything active. So follow-up is not really a big issue with out-of-station patients, and we've been doing it a lot. But I think the key here is effective communication, and you need to really be very clear on both sides, be it from the patient or from our side. We need to be very clear, and any amount of communication is always welcome.
Right, sir. Another question that came up right now is that on what basis type of surgery is being selected over here? I mean, that was a question that like I'll pass on to Dr. Vivek.
We have clear policy. As I already mentioned, we offer the gastric sleeve resection as the first option. Unless there is any other compelling reason, we don't go for a gastric bypass. So gastric bypass is a revision surgery. We offer it as second option only for those small group of patients who want further weight loss after sleeve gastrectomy. Only then we go for a gastric bypass. So first option is always gastric sleeve gastrectomy. Only very rarely, if there is a stomach, some issues with the stomach, like severe gastroesophageal reflux disorder, where is any or there are previous existing ulcers with the scarring of the stomach, all such things. Only then we think of other procedures. But the primary option is first option offered is always sleeve gastrectomy.
Right, all right, doctor. Thank you. So that comes I think, I mean, a few of the questions have been answered, and we have come to reach the point of where we closing the session. Uh, and yeah, so on behalf of the team, and I would like to thank Dr. Tom and Dr. Vivek for attending this session and making it a very wonderful way of communicating that there are options with people who have more, people who are actually they care for their body, and if they have, if they have more BMIs and all, they're stressed out. I think it's better they have to think about all these options that's available throughout, and how effective is being given out here, and how good Silverline Hospital is in that section. I would pass on to the doctor, Dr. Tom, just asking him what would you give as a straight message to the patients who are actually out there who are considering for this, and what are the options right now, just as a message,
I would say communication is the key. I mean, if somebody is struggling with this problem, there is help out there, but you shouldn't hesitate. Communicate very freely. Get on the web, talk to us. We would, like I said, we would enjoy, appreciate good quality communication, and we are there to help. We're there, all the time, 110%. Our team is there for these patients. So please just get on the web, communicate.
Thank you, sir. Right. Okay, so we'll finish up this session right now, and there is a recorded section which is actually being held up in the server, and we'll just put up the link as a follow-up email. And for all those who have, who hadn't any chance to attend this, the session will be mailed you back, and you could easily visit it over there. So thank you, Doctor, again, and for this wonderful session. Thank you.